Who needs no introduction, but Zeke is the Director of IR at South Texas Radiology Group in San Antonio. He is the Chair of our Reimbursement and Practice Expense Committees and leads our team at the RUC. He is the Iron Man on our team and is just brilliant.
Thanks. Thank you. Good morning. So when we talk about payment for physician services within the Medicare physician scale, the current most commonly used model is the RB-RVS. And I'm going to go through that acronym backwards, if I may. It's a scale of value. In a physician service, a radiology service, the value is determined based on its relativity compared to other existing services across all specialties. Your position on this relative value scale is based on the resources required for a physician to provide that service. The task of maintaining the RB-RVS falls upon the RUC, the Relative Value Scale Update Committee. And allow me to identify a couple of players in the RUC space. Radiology, the ACR is very fortunate that we have a permanent seat on the RUC. That seat is currently occupied by Dr. McGinty. Dr. McGinty's role in the RUC is as an independent individual evaluating the RB-RVS. By definition, she cannot advocate for radiology. My position is on the advisory committee for the ACR presenting radiology codes and recommendations to the RUC. I am anything but independent. I'm an advocate for the specialty, an advocate for our services. And to give you an example, at this last meeting, Chicago, a week and a half ago, we're sitting around the table, myself, some of the other advisors from the RSNA, Rink and Ray, SIR and ASNR, and we're having a discussion about some breast intervention codes. And for whatever reason, Dr. McGinty was on the pre-facilitation committee that was discussing these codes, and the chairman of the RUC, as busy as she is, literally walked in the room, tapped Dr. McGinty on the shoulder and said, "You can't be a part of these discussions." And it was sort of a dramatic moment when you think about how much influence Geraldine has, that someone would just basically pull her out of her seat, but it just highlights the dynamic that we see at the RUC. When we talk about total RVUs, and RVUs is the currency we use within the RB-RVS, well, there's a couple of components to that. There's the work RVU, and you can think about that as your work as a physician interpreting an examination, and there's a practice expense RVU. That's the cost a physician incurs in providing a service, loosely referred to as the PC and the TC. So in the imaging center or office-based setting, that piece of equipment, those resources, the staff, the supplies that a physician provides to enable that service falls under the PE RVU. The currency in most of our worlds is cash. So what we do is the RVU is multiplied by a conversion factor, and that sum is the cash that a physician receives for payment for those services. Coincidentally, the conversion factor is the number which many of us will be striving to protect tomorrow on the Hill, because that is the number which is influenced by the sustainable growth rate debate, the reductions, the 20+% we hear about every year. That's the number that's affected by it. So the recommendations that we make are a series of recommendations. The ACR makes a recommendation to the RUC takes our recommendation, makes it to CMS. It may or may not require a refinement. It goes back to CMS before a final decision is made. It's a lengthy process. At every one of these steps, the ACR dedicates resources to making those recommendations. It's a multi-step battle. And it's been a busy one. In the last 4 meetings, just over a calendar year, radiology has had 130 of our codes come before the RUC. When you consider there's roughly 650 imaging codes, include minor major procedures, it gets up to around 1,200. It's anywhere from 10 to 25% of our entire code set is coming to the table. And I think, as Dan nicely illustrated, that's a trend that's not going to end anytime soon. As Dan mentioned, coming in 2014 are a series of codes. I mentioned fluoroscopic guidance as one interventional code, but as Dan mentioned, there's embolization, there's stent placement, there's abscess drainage, all coming to the fee schedule with new values in 2014. Radiation oncology has been no short of busy within this process. David Byers in the audience, he's a phenomenal representative for ASTRO, works with the ACR in protecting the codes which are before you. If I may, I'd like to tell you a story. I'm going to call it a RUCous story. I want to tell you what happened this year to extremity MR. For my coding buddies in the audience, that's CPT code 73721. Let's go back to 2005. In 2005, the technical component payment for an extremity MR without contrast was $507. It's been subject to several what I loosely call well-known reductions. I've listed a few of them before you here. The DRA, the multiple procedural reduction, and as Dan nicely summarized, the effects of bundled codes. But what I'd like to talk to you for the next few minutes about is some not so well-known reductions. Because when the new payments hit the fee schedule for 2013, understandably, many practices, many practice leaders, many radiologists were surprised. So let's talk about the PERVU. Again, the technical component payment we receive for this service. This is the formula that CMS uses to determine practice expense RVUs. But instead of looking at it as a series of inputs, a series of formulas, think about it as a blender. And we take this blender and we input data, we input values, we input the cost of a piece of equipment, we input our practice expense per hour calculation. We hit the stir button and what gets produced is the practice expense RVU. Well, in 2013, one of the critical pieces of information within that formula, which is our practice expense per hour, was fully implemented based on a survey performed several years ago by the AMA called the Physician Practice Information Survey, the PPIS. Well, this year, in the background, the final 25% implementation took place, so now it's hitting the specialty at 100%. We talked about this last year. Total radiology surveys to this data source, 56. We've looked at the data in great detail. We said physicians providing this service in the office setting, and we used a relatively low number, we said would incur at least $5 expenses for staff, supplies, equipment. When we looked at that data, there were 9 surveys used to value the entirety of outpatient radiology. An important determinant of equipment payment is the equipment cost. How much we're paid for that MRI scanner that we're using for the extremity MR. And the formula is actually relatively simple. The equipment cost per minute multiplied by the number of minutes that piece of equipment is used. So let's talk about the equipment cost per minute. This is the formula that we use. But I want to talk to you about a specific element of that formula, and that's the usage. Well, the utilization rate has been all over the place the last few years. In 2010, it was 50%. CMS took it to 90%. Thankfully, the Affordable Care Act took it down to 75%. As was expressed by Josh and others yesterday, for 2014, it's back up to 90%. And that is just a simple number plugged into that relatively simple formula that I just showed you. Let's talk about the interest rate. Previously, the interest rate was 11%. The RUC itself, the American Medical Associations Committee, recommended reducing that to the Small Business Association rates between 5.5 and 8%. The ACR commented vehemently in our comment letters that this was an inappropriate scale to use. We actually recommended a weighted scale of capital costs, eloquently described it, traveled to Baltimore to CMS to express this to them. Nonetheless, this was finalized. I want to talk about the number of minutes used. So now we know how we calculate equipment cost per minute. Let's talk about the number of minutes used. Well, I cut this out of the final rule from this last year. We went to the table for an extremity MR, and we recommended, and the RUC accepted, that the amount of time that an extremity MR is occupied by a patient, not available to other patients during an extremity MR, was 63 minutes. When the final rule came out, Halloween of last year, CMS had refined it to 33 minutes, stating that it was refined to reflect the typical use exclusive to patients. We broke the data down, we looked at the impact analysis. And what we found in rough numbers, and it varies on a code-by-code basis, but in very rough rounding numbers, every minute of equipment time we lose is a 1% reduction in the technical component payment. Conversely, every minute we can gain of that equipment use is a 1% increase. It shows you the impact of a minute of time on a $1.6 million piece of equipment, such as an MRI scanner. So to conclude my story about the RUCous events occurring around extremity MR, The payment in 2014, and let's hypothetically suppose that for whatever reason, a patient receives a second study on the same day, and that second study is subject to the MPPR, a 50% reduction in the technical component payment. The payment will be $98, less than $100 for a complicated, complex study performed on a $1.6 million piece of equipment. And Geraldine and I had the privilege of traveling to CMS a few months ago, and when we shared this number with them, I think they were surprised at how cumulative changes have had a compound effect on the payment for the codes. We're hoping they'll take a step back and say we need to reevaluate this process. Coincidentally, I was actually told to go to the RUC and bring this to their attention, but I was promptly silenced when I informed them that their formula needed some updating and some upgrading in regards to equipment. Nonetheless, this is the conclusion of just over 8 years of sequential payment reductions. In the future, we're in the process of a PACS evaluation. We're converting film to digital inputs. There's an RVU validation project going on by both the RAND and the Urban Institute. There's several proposals for SGR fixes, which by definition brings uncertainty to fee-for-service payments, site-neutral discussions, and the ever-famous IPAD, the Independent Payment Advisory Board, which is a mandate from the Affordable Care Act, all bringing uncertainty again to the fee-for-service system, which we're working so hard to protect. And it creates challenges for us. It creates challenges for the ACR. Money. We estimate it costs us around $10,000 in staff resources per code. What I do is free, it's my pleasure to do it, but it takes staff time coming forward to provide those codes. We have communication challenges. It's completely understandable that practices were surprised by that figure that I showed you. The payment is about $215 this year for the single study extremity MR technical component. And it's a challenge for us because we don't actually see that final payment until around Halloween before the January 1st date when it's implemented. We expressed this to CMS a few weeks ago. We said we need the ability within confidentiality realm to express and communicate these reductions to our members because they have budget planning, they have salaries to consider, they have staff to consider, they have net present value calculations to make. And I think they understood, I think they get it. The reality of it is the Affordable Care Act has passed. It survived a presidential re-election. It survived the Supreme Court. It survived no less than 30 votes to repeal it altogether or repeal parts of it. And for the ACA to survive, fee-for-service payments can't necessarily thrive. Fee-for-service payments to specialists will continue to go down. And I'm enough of a nerd, okay, that one of my heroes is Jim Moorfield. Jim Moorfield was the father of the radiology resource-based relative value scale and subsequently the larger RBRVS. And we talked at dinner last night and someone threw out the term, now's our time to look for what our Moorfield 2.0 is. If you define what Jim did back with the Moorfield 1.0, when he created that RBRVS, and you look at how well radiology is done up until 2005, but I would argue even currently, within that system, if that system is no longer working, and that's a system, by the way, that everyone in medicine was scared of in the late 80s. Everyone turned their backs to, but radiology embraced it. Radiology dedicated the resources to ensure that that system reflected fairly and appropriately the payments for our services. Well, my colleagues, now is the time, and this is hard for me to say because this is my job. Fee-for-service is what I do, but it's time to embrace, determine, place the resources in to what's Moorfield 2.0. And with that, I'd like to close by thanking the RUC team, the individuals before you. In particular, I'd like to thank the staff that are excellent resources for the RUC. It's a tremendous team to work for. It's tremendous to work with Dan's team. And I'd like to thank you for your attention.